Good morning, and thank you to people who come and said hello already, and so on and so forth. You're such a lovely bunch. I'll do a line which I haven't had the nerve to do beforehand. So here I am, ready to go here, and so my missus is going, how are you going to start your talk? And I'm going, I don't know. So I thought, oh, I know, I'll do the old line, which is, hello, my name's Richard, I'm an alcoholic. Oh, sorry, wrong meeting. And there's a pause at home, and there's a, what is it that makes you think that they're going to think you're joking? So I stopped doing that for a while, as it didn't go down so very well. So I've been given the brief for 20 minutes, healthcare transformation, where to start. And heavens above, for 20 minutes, we're going to major on only where we start. And that was before the chairman said, no, 15 plus questions. So we'll be relatively brief. But I want to introduce you to some ideas that are well established and well out there. And see what you think about them, because you've been such a friendly bunch so far to come and say hello. So, I mean, isn't that a lovely picture? Isn't that just the sort of picture that you'd expect from a behavioural change consultant? All beautiful, and the whole world is ahead of you. Yeah, it's just not quite like that, is it really? So, within this audience, I've been hearing about the great amount of experience you have. Hands up, those that have been part of at least one NHS failed change programme. Oh, check. This is a more honest bunch than usual, usually about a third lie, because it's 100% of us, isn't it? So my impression is it's a bit more like that, really, in life, is my experience. And those cheerful pictures of the promised land in the future are just salt in the wound when you get into the departments, and I refer frequently to shoveling water uphill. Do not panic, there is a way forward. There is a research around this, and that sounds terribly pompous, but I can tell you lots of people have tried this, and experience tells us that there are some easy ways of doing this, and some difficult ways of doing this. So we're going to talk about some of the easy ways of doing this. Why am I pleased to be here talking about radiology? Well, all paths lead to radiology. I was a GP, I graduated in 85, general practice principal in 91, and for decades afterwards I no longer have a license. But the change in style, the change in practice of medicine this time, and let's face it, nostalgia's not what it used to be, is it? But I worked in a small town, and I had a friend that was a radiologist, I can confess in this audience, and we were going for a beer or something at 4:30, 5 o'clock, 6 o'clock, let's not do the detail. Nick says, I've just got to report this as it's just come in. It was a hot something. And he goes, oh, I don't know. Young surgeons of today, they can't they operate without taking a picture first? And I go, no, Nick, I mean, dreadful, the youngsters today, aren't they? Let's go and have a beer. What I hadn't realised was that was absolutely God's own truth. Generation from where I'm looking, new generations cannot do anything without taking a picture first. And I don't remember anyone doing anything with that piece of information. And so my understanding is that this is where it's ended up with. This is the King's Fund data. Diagnostic waiting time list. I presume this is your experience. Did I fess up to being married to a radiographer? I need to fess up now, yeah. 34 years and 2 days. So, is this your experience? How does that feel? I mean, that's a genuine question. How does that feel? That's a graph. What's it feel like? As good as that, eh? So I think that change in clinical practice has produced a predictable but not predicted effect. And I think when you go to work, and I don't go to your places of work anymore, you're wrestling with that downstream. So these are the calls for transformation. I really do have to refer to my notes on this one, because 10 minutes on Google, it makes me go that there's the NHS long-term plan, transforming imaging service, getting it right first time, diagnostic, the RCR census on workforce. So there's no shortage of calls for action. And you've told me that it's, well, you rather hinted that it's quite difficult being downstream of this pressure on the work. And so why hasn't it changed? So we're a behavioural change company. And so we're all smart people in this room. If we're still in a place that is causing us problems, then clearly something's not happening about change. And when I'm working with a group, which I don't do very often these days, I'll often say, I've heard two things about you. One of which is you don't like how things are. And they go, yeah. You work late, you spend a long time, yeah. And the other thing is I hear you won't change a thing. And that causes a bit of discord, of course. And resolving that cognitive dissonance is what we try and do at work. So this is a standard diagnostic that we use, understanding why things haven't got. So we absolutely understand there's a pressure for change. You were telling me that it's hard work, it's unpleasant. We have, might not be yours, but they are flying around a clear shared vision. All these reports I've told you about, and I'm sure you've read them all. It's this issue about capacity for change and actionable first steps that I wanted to think about today. I wanted to reassure you that I have some credibility. You'll judge, of course, but I have some credibility. I lead and manage a team of about 45 consultants, and we've been working in this transformation since about 2011. And we do most of our work is centrally commissioned from NHS England. And we use this combination of QI techniques, which we'll talk about a bit more later, and behavioural change techniques to deliver this transformation. And so we've been in about 1,300 clinical teams. And this is a big part of how we think it is, how we work. People do not mind change, they do not like being changed. And this is about 30 years old, this quote. Mo will probably tell me where it comes from, when it first was. So what we need to do is stop admiring the problem and think about ways in. So what's our core structure? Is this familiar to anybody? That's interesting. I got more yeses than I do normally. It's been around for about 30 years or so. Any experience in using it? Yeah. Good experiences? Less good experiences?
Good experiences, yeah.
Yeah? So it does make us wonder why it's not used more widely. So what we have here, so forgive me those of you who are familiar with it, but if I run through it, I want to go to the slide set, but I disappear from the microphone. So what are we trying to accomplish? And the thing that we come across there working with groups is what we're trying to accomplish is met by the phrase, it's obvious, isn't it? And we go, of course it is. Could you just explain that to me a bit more? Because as a team, we come to departments. We don't have the answers. And that challenges the medical model, the scientific model, because people are expecting us to come in, you have problem X, diagnosis is Y, treatment is Z, no problem at all. So we don't have those answers. We just have a series of really good questions. And we often find when people are going, it's obvious, isn't it? There's either a very big difference in what people want or a subtle difference. So we spend a lot of time on that. And then we want to know about how that changes an improvement. And we want to know about the change ideas from people. And then what changes can you make? I was reflecting this morning hearing the very eminent team talk about changes, wider changes in the NHS. And of course, our working lives will be different depending what happens in the budget in October. But our approach is all about working with what you've got. Colleagues were talking about vacancies. Yes, but this is what you've got. It's here and now. And I do worry that sometimes the NHS has a propensity to admire the problem and not get stuck into the solution. Other colleagues were talking earlier about, when we talk about, we like to spend much more time planning than we do doing. And I heard colleagues talk about, no one ever listens to people who really know what's going on, who are doing the job. We're still very moved from a change programme we did in Cornwall, GP practice. And they're gathered together in the evening, trying to get some change ideas about privacy in the front door, in the waiting room. And the cleaner comes over, she's hoovering away and goes, you need to move those chairs around there. And everyone sort of goes, what? Blimey, she's absolutely right. And she goes, have you any idea how many hours a year I spend moving the chairs around the place? Yeah, you know, the ideas come from. So it's creating that safe space. Psychological safety is a different issue. Creating that safe space for ideas to come. And then we get into this plan, do, study, act cycle, where we have a big think about what we're going to do. We do it. We find out whether it worked or not. And then we have a better idea and we do it again. And so you will notice there is no right answer. This is not evidence-based medicine where there is a plan or a pathway that I need you to do. This is baby steps run frequently. And this is the Einsteins that we do. If I was given 1 hour to save the planet, I'd spend 59 minutes defining the problem and 1 minute resolving it. when we're stuck, people go, I don't know what the answer is. It normally means they haven't spent enough time hammering the question. And within that, they've got inconsistencies in the question, and they're pulling different ways. So this is another mantra we say. So all improvement is a change, but not all change is an improvement. One of the things you'd heard us talk about was measurement, and thank you, Chairman, you talked about this idea of audit. Measurement is really important to us in all sorts of ways, and it's meant to be helpful measurement. At the planning stage, we talk about what we'll measure, and people say, well, that's not quite what's really important to me. We go, okay, what's really important to you then? And that works its way through. Because with the way we work, we really, really, really don't know what the right answer is. There is a fair risk that our intervention will make things worse, not better. So we need to check. We need to check that change is an improvement and not a worsening. And then the colleague was talking earlier about being lost in the system, not being incorporated into care pathways. We'll talk how long have I got, Chess? I don't remember what is broken.
Probably another 10 minutes.
10 minutes, great, thank you very much. We were working with one group and we talked about managing the information. And they were able to go, well, we normally do X of these. In this new pathway, we'll require Y. Where's the money coming from? Or what do you want us to stop doing? So that data gives you power. It also gives you evaluation of the effort. You've put change and effort into making the changes, and you know, because you've measured, because you want to know it's better, how much improvement you made. And you're happy to share that with anyone who talks, and we'll mention that a bit. Other expert colleagues have come up today telling me that they're expert in Six Sigma, and so our actual way we work is actually a bit of a Six Sigma, lean processing, and QI. So there's other stuff in it. So this would be, and I'm very proud, and so I'd like to ooh and ah later about a paper that's on our front desk that we published in RAD that we talk a bit more about this. But you'll see how we go. We define. Now we're taking that a bit further because in conversation we've understood really what's driving people, what's driving those people there and then, not what's important in a different paper. And who should be involved? That's another step we do. Understanding who's holding the checkbook is an easy one, but it's one that's surprisingly often left out, and how to achieve those changes. We measure, you've heard me talk about the importance of data for our own progress and reassuring colleagues. And then this is the time when we're working with a group, we'll introduce the model for improvement. And then analyse those current measures. What have you got at the moment? It is my suspicion, and you will know better than I am, that most of the data you get in managing your departments is to monitor financial flows, not to increase process efficiency. And having this work, you can, because you've really hammered the question, you can then go to your data providers, internally or externally, and go, please can you tell me the number of these because? And most people, when presented with a please phrase, will go, yeah, sure. They're actually so delighted. They're actually so delighted that you're actually talking to them that actually comes off. So you can start to collect data and create a dashboard for change which is relevant to you, and get rid of the stuff that's important for the financial flows. Then you get on and you do your stuff. You use your dashboard, and that introduced evidence-based decision-making is not published evidence. It is what you have gathered that works in your place. I have met today, and it's been lovely, thank you. I've met teams with half a dozen consultants. I've met teams with, from what I can work out, 600, some of the bigger ones. So what works one place won't work the other. Same question. So we've gathered our questions in roughly the same places. I can't do the whole one-year MSc in 20 minutes for you. But we don't have the questions as this is our approach to a department. We don't have the answers within those, but we have a series of questions that make things clearer. So for example, in skill mix, and I know how important that is in making optimum use of your workforce working at the top of the license, we have skills audit. For understanding clinical pathways, we have process mapping. And all this is designed to make visible what's currently invisible so that smart people can make smart decisions. And this is our problem, isn't it? For every complex problem, there's an answer that's clear, simple, and wrong. And I think it's even worse in our sector, because I think healthcare professionals have come to a position that if a patient answers the question, they should come up with an answer. I think NHS management culture has come up with a situation that if someone asks a question, you should have an answer. And sitting there is, I don't know, I'll go and find out, isn't fashionable where I come from. And this is exactly the root of ours. We do not have the answer. We will run the experiment, we'll do things which we're likely to be better, but we will take baby, safe steps. We will stop and check that our change is an improvement. Does it work, this approach? Yes. I mean, you would expect me to say that, wouldn't you? I mean, my notes say Mandy Rice-Davis for those of a certain age. Mandy Rice-Davis applies. So we did a literature survey, and that's published on the front, and there's very little published in the medical literature. And that's because operations management, which is what this is taught in the business schools, not in the healthcare schools. And that's why many people don't know about it. But it's an old established science, and it's there. Does it work for departments? This is the theory. So I've taken some stuff out of an intervention we did. One of the modules, you saw the circle, managing our information. Yes, that we save time. It tends to be the most common unit of benefit is saving time. And so what it saves people time in that. You'll notice it saves a range of people time because we spent some time thinking who are we going to involve. And you'll notice that's what they chose as their measure of what success was. But also, you heard earlier colleagues talking about morale and motivation and whatever. And I think one of the reasons I want to major on this is because there's a culture within the NHS that change is bad because it causes you grief. We've already heard, Chair, that people stay late already. I now want you to work harder and longer. Oh dear, that doesn't sound very attractive. So these are a couple of quotes. I'll leave them on the screen. It's actually people feeling, oh, that's better. I can do my job. I know what's going on. Stress levels have gone down. I feel more confident, competent. I feel I'm managing the department. We're future-proofing the process as well. I've talked to people who don't feel valued. I've talked to people who feel powerless. And this sort of approach gives you a power over change, and it makes it safe because it's small and frequent. So I started off by giving you this chart. I don't know where it came from. It's one of our first slides from when we started the company in 2003. So if anyone knows that I've got an academic quote I should be doing, I don't know where it's from. But I think I've given you lots of actionable first steps that can be taken. And the trick is to make the actionable first steps small enough that you can succeed. Nothing succeeds like success. But funnily enough, by a couple of successes, you start to get the capacity for change. One of which people goes, oh, this could be better around here. And then people's resistance to change drops because they go, oh no, this is safe. And this, because you gave them a good listening to at the start of the program, this works for me. And you know that because you listened to them at the start of the program. And so I think it's the combination there that you get into a virtuous cycle. And that is when you've started, you've done one or two, people start to go, this is good. Is there anything else you can do around here? Because my working life is made horrible because of. And that's when you get off starting the transformation to running proper transformation. Thank you very much. How do I do?
Perfect timing. Thank you very much, Richard. I might have to secure all of those things for you. Any questions from the floor? You have with us? Yeah.
What's the best way of changing the culture of a place on a large scale?
Little and often. Culture, let's take the original definition of the way we do things around here. That can come from values driving behaviours, but sometimes the actual changing the behaviour is more difficult. So the way we approach it is we don't go, you've got to be safe, you've got to be reliable. We just look at the measures and go, what measurement here would be good for you? And you start plotting the effect of the behaviours. And that gives a culture. The most, I haven't said that very well. Let me give you the most, I've never dared do this. This example came from the States, and I've heard of it being done, and I offered it a couple of times, and everyone's turned it down. Primary care facility, 3 jars, 1 full of marbles, 1 labelled, today the doctor was nice to me, today the doctor was not nice to me. And as coming out, the patients were invited to take a marble and to put it in which one. They'd wrestled with this clinician for 3 years. In 3 hours, he never put another foot wrong. So what you're doing there is setting up feedback. That's a feedback loop that doesn't support bad behaviour, but you also set up feedback loops that support good behaviour. And you can't do it. Tomorrow you're all going to be well behaved. But the most powerful way of changing that behaviour is you have not done what you said you were going to do. I've got a measure. You said you were going to be nice to the patients. I've got a measure that says you're not.
So you mean like collecting feedback, talking to the patients?
If that's your area of problem,
getting numbers.
Yeah.
Data collection.
Yes. And really, and can I advocate to you the quality of the conversation and discussion required to get the right measure? It's a long way from, I think you're a bad person. It's to, I think a good person does this. I don't care whether you're a good person or a bad person. I just need you to do this. And chart. And the more public you make the results, the more powerful your intervention.
That's the gentleman over there.
I'll talk loudly.
Oh, sorry, microphone's coming.
I guess I've studied QI, so I was more in terms of like understanding processes and mapping processes. What your view on how the NHS should be better at sort of looking at process mapping before you start doing the models?
Well, I suspect our experience is the same. Start doing it would be really good. I mean, process mapping is great, and then we normally have a series of modules that we offer, and we try and start with something that lends itself to that, because it is so visual, and people just go, oh, I get it. Example I can give from when I was in practice a decade ago, it's still relevant. We closed the surgery like we do now, and we were talking about repeat prescribing. And my head receptionist stands up and says, and we get the prescription, and we check the last outpatient appointment. And with one voice, the docs all groan. And the head receptionist goes, what have I said? They go, that's what we do. You don't need the brain of a planet to go, well, shall just one of us do it? And it's so, and there's no imposed change. You notice how people are making choices. I now choose that I will do that. And that's very different from being told, go and do this or else. And that goes back to my morale and positivity and agency and control.
Anything else? So I've got a question.
Uh-oh. I hoped I was going to be rescued from the back. I'm out with the chains on floor.
Is there another industry you can look at that has done this really, really well?
Aviation.
Aviation.
We have a site. We have a side hustle in aviation, and the politicians will tell you, "Oh, the health service can learn a lot from aviation." It can, but none of it is what the politicians think it is. If I went to the flying school with the NHS culture towards safety, they would take the keys of the airplane off me.
And I suppose here's a difficult question. Why is
I found the last one slightly. Yeah, right.
You think it's centrally commissioned by the NHS. Why isn't the NHS investing its own internal resources with people like yourself as opposed to bringing in consultants? And I'm sorry, are we spending too much money on consultants when we should be investing this sort of mindset internally within the NHS?
I'm going to push that back because I think that reveals your mindset of me.
Absolutely.
We are a for-profit company. So I had to get out of general practice and earn some money elsewhere to do this. Yeah. So I am one of those fat, filthy consultants that the Daily Mail reads about. Oh, I wish it was that good. My opinion is the last 14 years have been all about short-termism. And if your major measure is short-term waiting list, then you'll get the short-term waiting list. What the Daily Mail says on Friday resonates through. And I was talking earlier about lovely stuff about capital investment. We were talking about scanners getting old earlier, and I'm going, oh yes, of course, in a for-profit, you'd run that in your balance sheet, you'd depreciate that across, you'd have, oh yeah, NHS doesn't do any of that because, is that tomorrow? Because I'm the health secretary and I'll be out of here in 3 weeks for the next one, and I need it to result by 3 weeks. So you have this short-termism. The GP transformation programme that we deliver for NHS England, I was told, was the only transformation programme that survived the end of the last administration. I am hoping, note commercial conflict of interest, it will come through. The next one will come through.
Well, thank you very much. So I think with that, a big round of applause to Mr.
Thank you.